we are going to talk about the medications, mental health medications for schizophrenia. The first generation antipsychotic is an example of the earliest drugs for this treatment. Remember, I spoke the other day and I said these drugs really revolutionized the treatment of schizophrenia. Up until these drugs were available, patients had to be institutionalized. They were not able to function in society, hold a job, depending on the severity of symptoms. Schizophrenia was a very difficult condition to treat, especially those with overwhelming positive symptoms, hallucinations, paranoia, delusions, which can be quite severe. These patients couldn't be treated. Even psychotherapy was not sufficient because these patients were typically actively having invasive thoughts and were unable to cooperate with therapy. When first-generation antipsychotics, in spite of all of their side effects, which we are very familiar with now, they were an effective drug and useful for these patients that we didn't have any other way to treat at the time. So they really revolutionized the ability to care for these patients beyond just putting them in a mental hospital. So the first generation drugs, Haldol is still a drug which is used today. It is, in spite of the side effects, it's very, very good at controlling positive symptoms. Haldol or haloperidol, the longer generic name. The other drug, fluphenazine, Navane, Thorazine, Mellaril, these are all fairly common and still in use. We have second generation antipsychotics that have far fewer side effects, but sometimes you will end up using a first generation if a second generation antipsychotic doesn't control the symptoms. So the first generations are still very, very good drugs. These drugs target the positive symptoms, as I've highlighted here. Currently, the advantage of these drugs, they're less expensive. Now, it makes sense that they are less expensive. They're an older drug. Most patients can afford these. These are very affordable. Some of the antipsychotic second generation, the atypicals, they can be more expensive. Some patients can't afford them, and you'll lose compliance because of the cost of the drug. The disadvantages of the first generation drugs are shown here. They do not treat the negative symptoms. Now, just to remind, we talked about negative symptoms. The negative symptoms still affect the way these patients will interact with others, families. The negative symptoms are still a factor. So the disadvantage of this first generation, as good as it is for treating the positive symptoms, it doesn't treat the negative symptoms. The other side effect disadvantage of this drug is the extrapyramidal side effects and tardive dyskinesia. The EPS, can you distinguish between EPS and tardive dyskinesia? Tardive dyskinesia characterized predominantly by the facial movements. That can be tongue protrusion, it can be smacking of the lips, involuntary blinking. Those are the things that when we interact day to day with other individuals, they're noticed. So that can impair one's ability to function. The EPS, they're also significant. Patient with Parkinson's disease, the rigidity, those muscular abnormalities, the dysfunction associated with that type of patient, those characterize the EPS. So EPS and TD, they are distinct but often confused. TD symptoms are not reversible. So you want, as soon as you start to see these symptoms present, you want to do what you can with the medication, whether that means change the medication, alter the dose, because they're not reversible even when we stop the medication. So we have to be very vigilant. Anticholinergic side effects, like we talked about the other day, and I mentioned anticholinergic effects, they always show up on these exams. The NCLEX, PANCE, USMLE, these are always asked. So we talked the other day about anticholinergic effects, how we can group them. Think about the parasympathetic nervous system and the sympathetic nervous system, and that's how you can remember them. Give me an example of an anticholinergic side effect now. It's easier to come up with a group of symptoms that fit under that heading of anticholinergic side effects. Lower seizure threshold. So in patients who have a history of seizure disorder, you're going to be cautious. The other side effect, weight gain, sexual dysfunction, and endocrine disturbances, they are real. In particular, weight gain is one that often results in noncompliance, I have found, in female patients, because body image is important. And these medications are taken daily. Sometimes the dose has to be adjusted up or down based on the symptoms, but it is the action of this drug, its effect on the receptor as a byproduct of the way the drug works, its mechanism of action, that causes weight gain. So that's another one where you might have to lean towards an atypical antipsychotic if this complaint is one that's really bothering the patient. How do we administer this drug? We can administer it PO, orally, IM. The advantage that I have found with IM is that in patients who are non-compliant, patients that forget to take their medication, patients who may live alone, that don't have a family member monitoring, this is a real advantage. They can get an injection, and then they only need to return to the office for their injection. They don't have to take a pill every day. Next slide. First generation antipsychotic side effects. So we've talked about these now. The more common, the EPS. We can describe them in terms of dystonia. They can be acute. They can result in sustained contraction of muscles, rigidity. This usually involves the head and neck. Akathisia, just briefly to define. So that's characterized by the inability to sit still. Sometimes you'll notice this observing these patients in the office. An inner restlessness, that's akathisia. Pseudo-Parkinsonism, I alluded to earlier. If you can remember this certainly helps you remember the EPS, and distinguish it from TD. The treatment is anticholinergic drugs like benzotropine, Artane, Benadryl. Benzotropine, quite common. Side effect is a little bit of nausea in many patients, but they work. TD is persistent. It can result after prolonged treatment. Remember, I said that it persists after the medication is stopped. The movements, involuntary twisting, contraction, the tongue protrusion, especially movements of the face, lip smacking, and I've highlighted that it is irreversible. Always vigilant, stop the medication or change the patient's medication if this occurs. The next bullet point, abnormal involuntary movement scale, that is something that we can use to track TD symptoms. Whenever we notice a change, notice this is administration, it's administration key nursing role. So this would typically be done every time the patient comes in. If the patient's being seen monthly, this would be one of the things that we would complete and add to the chart. If there's a change, then we'll make a change in that medication or in the dosing. Second generation atypical antipsychotics. The class of drugs, serotonin, dopamine antagonists. You recognize both of these neurotransmitters. Serotonin, neurotransmitter that we talk about for mood elevation. It can treat both positive and negative symptoms. This group, the atypical antipsychotics, this feature distinguishes it from the first generation. I mentioned earlier, since we have the ability to treat positive and negative symptoms, why don't we just use this drug exclusively? This drug is typically the treatment of choice, and that is because of less side effects. Notice here, there's no extrapyramidal or TD. The disadvantage is a tendency toward metabolic syndrome. So some of these symptoms that, in particular, weight gain, altered glucose metabolism, not all patients will have major side effects, but many of them will. Side effects affects compliance, and that's what we're primarily concerned with. We want these patients, if they need to take their medication every day, we want them to take their medication every day and not stop or hold their medication because they're experiencing side effects. Atypical antipsychotics, you need to recognize these as a class. On the exam, you are expected to, if presented with a question with a first generation, you're expected to recognize it as a first generation and all of the side effects and all of those features of that drug class. The same is true for the atypical antipsychotics. If you're given a question where you are asked about side effects or keep an eye on the endings, these are important. You have to recognize them, each drug. All of the 5 that are listed here, I have seen on questions that you will encounter. Risperidone, olanzapine, Seroquel, high yield for this exam. The others that we talked about, fluphenazine, Haldol, those are important first generation, and you will be asked those. I will just remind that it is the generic that you need to be most familiar with. You may not see the trade name. Third generation antipsychotics. So we've talked about first generation, second generation, third generation, in order of how they were made and when they came on the scene. Abilify improves the positive and negative symptoms. In assessing these patients, it's straightforward. You can ask them, are they experiencing hallucinations? They will tell you. And so some of these patients have a fair amount of insight. You may adjust the dose up or down in order to limit those symptoms. Abilify has some side effects, but in truth, it doesn't seem like patients can complain that much about or report, I will say, the side effects to Abilify. It's a dopamine system stabilizer. Again, little risk as a third generation antipsychotic, little risk of EPS or tardive dyskinesia. So that's a huge plus with this class of drugs. So overall, it has a better safety profile than the second generation. What are some potentially dangerous, life-threatening responses to antipsychotics? They're shown here. Anticholinergic toxicity, a good question for the exam. What is anticholinergic toxicity? We've talked about, you listed 5 common anticholinergic symptoms. This is anticholinergic toxicity. So we see these side effects to a greater extent. And I have a slide that I can show you on those. What is NMS? One of the most serious side effects of the antipsychotics. So these patients have a high fever. They have irregular pulse. The heart rate tachycardia, 120s, 130s, 150s, increased respiration, muscle rigidity, altered mental status. This is an emergency situation. When it occurs, these patients are transferred to the unit. Dantrolene is the drug that we treat patients with, and that's a need to know. That's particularly high yield. That is the drug that is administered. If you're given a history of a patient on an antipsychotic and you have this autonomic instability, heart rate, high fever in particular, a fever can be very, very high. This can be rapidly fatal if it's not recognized and treated. The other potentially dangerous side effect is agranulocytosis. What are granulocytes? Leukocytes, white blood cells that have granules, in particular the basophils, eosinophils, and neutrophils. This can be life-threatening and can result in infections. These cells are on the first line of defense. So we talked about dilated pupils, photosensitivity, blurred vision. We see non-reactive pupils, hot red skin, hyperpyrexia, tachycardia, agitation, delirium, urinary retention. All of these are related to, if I asked you to list the anticholinergic symptoms, you would list many of these to a lesser extreme. Not to be confused with NMS. The treatment is contact the MD, don't give any more of the medication that initiated the symptoms, take emergency cooling measures. A little bit of detail here about NMS. This is a life-threatening emergency. Severe muscle rigidity, response to dantrolene, hyperpyrexia, diaphoresis, sweating, extreme tachycardia. First, stop the medication, transfer to the unit, immediately do what needs to be done in order to decrease the temperature. That can be cooling blankets, all of those techniques that we use in order to reduce the patient's temperature in extreme hyperthermia. Hydrate the patient, IV, so intravenous access, fluids, and the way to save these patients, prevent fatality in this group, is to detect early, administer dantrolene, and take all of these other steps. Detection increases survival. Agranulocytosis, the next slide. This is the reason why this drug isn't used as much as it was in the past, Clozaril, because of the agranulocytosis, the risk of neutropenia, and sepsis that can result in patients who are on this medication. And the condition is acute. So the patient presents, you check the white blood cells, and the white count is very, very low. The normal white count, you'll need to know levels for your exam. So in most labs, that is between 5, 5.5, and 10.5, in that range. So you'll see white counts of 2, 3, quite low. And the most significant affect the neutrophils. And the neutrophils are the first line cells for fighting infection. So overall reduction in granulocytes, with neutrophils being affected primarily. And so these patients are at risk for serious infections. And if they do get an infection, then they're at risk for sepsis. And this can be fatal. So the treatment is how we would treat sepsis or how we would treat an infection. So we want to stop the medication and then monitor the patient The patient may need to be monitored for infection, and you may need to do things that would lower the patient's risk. Mask wearing, limiting contacts until their white count responds. Monitor CBC, change medication.